Welcome to the Heart of Innovation. 60 minutes that could save life and limb, with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by patient advocacy group thewaytomyheart.org in partnership with Cardiovascular System Incorporated's patient advocacy campaign, Take a Stand Against Amputation. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of The Way to My Heart, Kym McNicholas, and interventional cardiologist and founder of the Save My Piggies Health Education Series, Dr. John Phillips.
Welcome, everyone, to the show live in Venice, Italy at the CLI-C Global Conference. This is a vascular conference. It's focused on peripheral artery disease. It's a big problem across the globe, especially with the diabetes epidemic out of control. It is one of the top vascular complications of diabetes. It's a circulation issue in the legs, and it can lead to heart attack, stroke, and especially amputation. It's the leading cause of amputation actually across the globe as well. But we're here, of course, my co-host, Dr. John Phillips, and we got to meet for the very, very first time. And we're going to be joined by Dr. Mariano Palena, also here in Italy. He is the co-founder of the conference, and we'll say hello to him after I hand the microphone over to John. I could just easily hog this today.
We've had a lot of fun here, so you can hog it if you want. But no, I'm having a blast. We're really, I think, getting to know some people, learning a lot about the culture, learning a lot about how the disease, peripheral arterial disease, is treated around the world, and just really excited to talk with Mariano, our co-director of the course. Mariano, how much time does it take to organize this thing?
Well, first of all, John, it's a big pleasure for me to have you here with us, as well to you, Kym. So thank you for both of you to be here, to joining us in this very big project and interesting project. Organize this meeting. The time we finish, we start again. So it's 1 year organization. It's very difficult for every one of us as physicians to organize the agenda, to participate in multiple meetings. So we must to decide the faculty and invite the faculty very soon to be sure that they will participate as well. No one of these projects can be done without the support of the companies. So we must to be ready to discuss with the companies about the support they will provide to us to be ready and sure to be able to perform the meeting.
So the conference itself is focused on the most severe consequences of peripheral arterial disease, critical limb ischemia. Why did you feel like you needed to focus on that specifically and have experts around the world discuss how they treat this really complex patient cohort?
The meeting is focused on CLI and diabetic foot. Why is important? Because, as Kym said, there is an epidemic, a pandemic all around the world about diabetes. We know that we have a big number of underdiagnosed or undertreated patients that are suffering an amputation today, but we also know that the number of patients that will need this therapy in the future will increase dramatically. So the idea and the focus of CLI-C is a practical course to create or to give to try to teach or to try to everyone learn from the others about what is the evolution, about what we can do today to help those patients.
One of the highlights that I love about these conferences, and particularly here, are the live cases. And to paint the picture for people who are listening and have never been to a conference like this, you actually have the opportunity to watch peripheral artery disease specialists, interventionalists, and surgeons actually perform the procedure live. And they have a panel of peers, right, sitting on the stage that are interacting with the specialist. And even more, at this conference, the audience, other physicians, industry, researchers, whomever is here, can actually interact with the person performing the procedure as well. Can you talk about the importance of that and how it differs here versus even other conferences in its class?
The focus and the mood of CLI-C is to have live cases. For us, it's not a congress, but it's a course. It's a course in which everyone can learn about the others And the main topic, the most important thing is the live case, because the idea is to change the minds. We know that we can help those patients, not all of them, but a big number of them. And the idea is to try to, in some way, give the opportunity to others physicians to understand that finally what we do is repeatable, can be performed, but a lot of people, for sure, you need the skills, you need to be trained, but it's not something just for few physicians, but it can be make for a big number of physicians. And in the future, we will need a big number of physicians interested in CLI, because we will have a big number of CLI patients.
And John, you actually, are here not only presenting, but you're here learning, and you were there watching both Mariano Palena as well as his partner, Dr. Marco Manzi, performing these procedures. What's it like for you being on the receiving end of watching these procedures, learning and bringing things back to the States to use? Because these guys here are really pioneers.
Well, I mean, I'll take it a step further. It was probably about 7 years ago, myself and my partner, who's now retired, we came to Mariano and Marco's lab and spent about 5 days learning their techniques, because we, at least in our lab, we had trepidation about being as aggressive in the vessels below the knee and as they were, and just wanted to learn from the best. And so it really changed my practice. It changed how I approach treating patients. And I have to thank these guys for what they do and what they did for myself and our group. We now have a critical limb center at our hospital. And I actually wanted to ask Mariano, because I quote this a lot when I give talks in the U.S. about critical limb ischemia. I mentioned the center of excellence approach that you have in Italy. And because of that, you have, I think, some of the lowest amputation rates in the world. So it's not just us opening up the vessels, but it's a wound care specialist, it's a surgeon, it's someone helping with their diabetes or their tobacco cessation. So can you share with our listeners back in the United States what it's like to have an ulcer in Italy, and how that care is such that they go to one place and I think they get a treatment plan, if I remember correctly, that they can then take to their home?
Yeah, well, as you said, we work in a dedicated clinic for diabetic foot. The idea is to work in a multidisciplinary team. This is I personally think, the only way to help people with critical limb ischemia and diabetic feet. As you said also, what we do opening the arteries is 1/3 of the procedure or 1/3 of the care. Because in the multidisciplinary team, we have clinicians that take care about every clinical aspect of the patient. There are us as a vascular specialist and dedicated wound care or foot surgeons. Without this multidisciplinary approach, we know we have a lot of fatigue, but we cannot help the patients in the proper way. So if you have an ulcer today in Italy, there are 3 or 4 multidisciplinary centers, most of them in the north of Italy. You can call, you will receive any information, and for sure you will have the chance to be seen by a dedicated for one of the physicians of the multidisciplinary team. And the process starts with the first visit. They will evaluate your risk factors, comorbidities, and so on, the Wi-Fi classification for your foot, no invasive Doppler ultrasound check to realize if you have peripheral arterial disease or not. And they will give you all the necessary information, but also they will provide you a specific day to be recovered to perform the angioplasty, and after the angioplasty, the necessary wound care. I mean, if you need the debridement, minor amputation of the foot, or just an ulcerectomy, foot surgery, it will be provided in the same session. I mean, on Monday the angioplasty, on Wednesday the foot surgery. So you will be back home almost ready.
And as John had mentioned earlier, you guys are pretty aggressive in your approach to treating peripheral artery disease and unblocking the wounds. Well, it's a matter of life or limb. If you are not aggressive, then this person is likely to lose their leg. And if amputation is on the table, why not at least try? I mean, that's at least what I would think. That seems logical to me. But as you are showing these physicians who are in the audience at your conference how aggressive you are and to exhaust all efforts, do you find, or have you found even during this conference, that there's still some hesitancy, there's some resistance, maybe some pushback from those in the audience that are watching you go to great lengths to save each person's leg?
So we are aggressive taking care of the patient. We absolutely ask the patients to change the risk factors, to stop smoking, to take the medicines to control diabetes, and so on. We are also aggressive taking care in some other aspect. For example, I'm specialized for the vascular surgery or endovascular surgery. So I think the patient has, in most of the cases, one chance. So we cannot stay there seeing if we remove an stenosis in the proximal inflow of the leg could help to improve the flow for the foot. That's the reason why we can be considered a bit aggressive, because we want to provide the best solution for the patient once at the first time.
Thank you so much, Dr. Mariano Palena. We really appreciate you having us here at the event. Coming up right here on The Heart of Innovation, more live from Venice, Italy at CLI-C Global. So stay with us.
Leg health can indicate risk for heart attack, stroke, and amputation. If you have leg pain or cramps while walking, get checked for peripheral artery disease, or PAD. PAD is plaque buildup in mainly the leg arteries. Be sure to ask your physician for an ankle brachial index, also called an ABI test, where they use blood pressure cuffs to analyze the blood pressure in your legs. If they discover you have arterial plaque that's limiting blood flow to your feet, medicine and a regimented walking program are frontline treatment. If PAD is in its advanced stages, your physician may schedule a surgical intervention. Minimally invasive tools are available to remove plaque and restore blood flow, including Cardiovascular System's Diamondback 360 atherectomy system, which sands away plaque that is a hard calcium. It's important to discuss all options with your physician, and if told you have no options, get a second opinion. Take a stand against amputation. For more information, go to standagainstamputation.com. That's standagainstamputation.com.
Welcome back to The Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody, to The Heart of Innovation. I am beside my fantastic co-host, Kimberly. It's been a long conference, an excellent conference, though. And, during the break, we were talking. You had asked me why I come to this. Obviously, it's nice to be able to go to a conference that's outside the U.S., that's in a beautiful city, Venice, Italy. And the weather's been fantastic. But at the end of the day, I think we choose to go to conferences that we know are going to help us. Let's be honest. A lot of the data that we see that's presented is recycled, it's kind of it's rinsed, repeated. But here you alluded to this with Mariano, these are cases, we see case after case of complex intervention that, in my opinion, is not always being done at some of the other conferences. So it's, for me, an opportunity to learn something new, but it's also networking. And you're meeting other physicians from other countries. You're learning their techniques. You're learning what works, what doesn't work. You're learning what their passions are and how they are being advocates for their patients. I believe at some point we're going to be speaking to one of the physicians in Canada who has a project that he's after. It's the weight of my heart, and we do save my piggies. But I think the nice thing about it is you come here and you see people that have the same passion that you have. And it's kind of like this little nucleus of vascular geeks that like to open up vessels below the knee. But at the end of the day, our objective is to learn and help patients so we can prevent the amputation and ultimately save the leg and the limb.
I think it's incredibly important, especially when we do see a lot of the studies that are put out by large universities, large facilities, et cetera, that are using a retrospective look at, let's say, Medicare data. And there's no telling, well, what is the skill set of that physician that performed a particular procedure and did or did not save a limb or a life? Here, you can actually see what some of the most advanced physicians in the world are doing and how they're doing it, and step by step. And I think that that's absolutely priceless. You can't actually read the impact on paper.
Well, I mean, case in point, we've talked about a recent trial that was published regarding surgery versus endovascular, so balloons and stents for people with critical limb ischemia. A lot of holes have been poked in that, but there are a lot of people and physicians that go to conferences and they go to learn. Some people go to interact with other physicians. And there are, I think, a section of them or subset that don't know what their potential is. And when they come to some place like this and they see complex cases, it takes the governor off of their trepidation for being more aggressive and ultimately helping their patients. Like, to your point, a patient may call you and they live in Kansas or something, right? And they have a wound that's not healing and they're not getting the care that they think that they should get. You find them a physician sometimes, but oftentimes there may not be a physician in that area, but there could be, and it's potentially because of a conference like this or the Weight of My Heart or whatever other conference in the US that you turn a physician who's not a CLI fighter into somebody who does.
And I think that's one of the biggest frustrations for me in coming to a conference like this, is because I learn what's possible. I see the most complex cases that are successfully being navigated. And then I have a patient who calls our organization, which is an advocacy organization for people with peripheral artery disease. And if they say that amputation is on the table, we want to do our best to go above and beyond and find them a physician that will go above and beyond, that will try, that has the same skills as what we see at conferences such as this one. But what's frustrating is that we can't always find a doctor with these skills. And that is actually what keeps me awake at night. It's like, oh my gosh, I have this person that is in the middle of nowhere in the Philippines or in the middle of even the United States, where the nearest hospital is like 20 miles away. And that hospital doesn't have someone that even can unblock a vessel below the knee. And if they can, they don't go to the foot. And I have to tell this patient, well, I know it's possible if you get on a plane and you fly to the next state over. I wish, and I don't know about you, like, how do we get more physicians to attend not just their basic industry conference? Every physician has to do what's called continuing medical education. Their CME, they need these credits. But so many doctors just go to their general industry conference or they watch a few seminars and they don't know what they don't know. So they don't even know what seminars to look for or what advanced conferences to look for. I mean, how many general vascular specialists know what it means to be a CLI fighter?
Well, I mean, you make a lot of good points there. The problem that I see is these cases they're complex, they're long. They do take resources. They can be expensive. Although when you come here to Italy and you see what they use, basic wires, simple catheters, balloons. So the cost of the procedure, the actual cost is fairly low. But in the US, they can be very expensive. And this is just my opinion, but if you have a physician who does some peripheral arterial disease work, but also does coronary work. And maybe their allegiance or their passion is more in the coronary. Well, they're going to do probably more coronary cases, which are quicker and easier. You can knock those out. You could probably do 3 stents in the heart by the time it takes to do one of these cases. And so that's what people think about. So really, not that I've given up on when I say our, meaning physicians' ability to, pick up that phone and call Dr. So-and-so, hey, it's John Phillips. I can't do this case. Can you do this for me? We don't do that. What we do oftentimes is we just say, oh, there's nothing can be done. And so I think the patients have to be, and I've said this before, the quarterback of their care to tackle or to at least address their issue, get a second opinion through the Way to My Heart or other organizations, and they have to travel. If they have to travel, they have to travel. But it's an unfortunate reality that we live in.
Well, coming up here on the Heart of Innovation, we're going to have more live from CLI-C Global in Venice, Italy. And we are talking to Dr. August Iza from Spain, and we're going to see what's caught his attention and what he's learning here at the conference. So stay with us.
3 years ago, my symptoms started with leg pain and leg cramps while walking.
Me too, with a tightness in my calves.
Well, do you know, my doctor thought that my leg cramps were a side effect of the statin he prescribed me.
Well, my doctor just brushed them off as another symptom of old age.
Mine thought the pain was radiating from my spine.
My doctor blamed my neuropathy on diabetes until I got a wound on my foot that just wouldn't heal.
Yeah, it turns out we all have peripheral artery disease, also known as PAD.
It's plaque buildup mainly in the leg arteries causing poor circulation.
For me, the diagnosis came too late and I lost my leg, but that does not have to happen to you.
No, it does not, because there are treatment options available if you're diagnosed early enough.
PAD. Peripheral artery disease. If you've been experiencing leg pain, leg cramps, or neuropathy when walking, and your doctor isn't hearing you, we are. We are the Way to My Heart, the largest support network for peripheral artery disease patients, and we want to help you get back on your feet again. Visit our website at thewaytomyheart.org or call our Leg Saver hotline, 415-320-7138. Your life and limb could depend on it.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back to the Heart of Innovation. We are live in Venice, Italy, and we're so excited to be at CLI-C Global. We have vascular specialists from around the world that are here, and they're learning all kinds of new things, new tools, new techniques. They're also learning best practices for treating peripheral artery disease, which, as we talk about all the time, and as we've talked about earlier, it's a circulation issue in mainly the legs that, if not treated early and in the appropriate manner, it can lead to amputation. I'm here, of course, with my co-host, Dr. John.
Hello, Kym. This is an amazing conference, and it's also actually the first time you and I have met.
In person.
Each time we do another section, I always have to remind myself from pitch. But no, I'm having a great time meeting a lot of interesting folks. We're discussing the latest kind of techniques in treating folks with critical limb ischemia. Mm-hmm. And it's always great to hear what people around the world are doing. So having a blast.
And I actually have the honor of introducing you to Dr. Iza. And Dr. Iza and I met actually here last year. And this is the first time you met, and he is from Spain. And this is also the beauty of it. I mean, people from all over the world, welcome.
Yeah, thank you so much, Kym, for your invitation. Yeah, completely with John. It's like amazing to have the chance to meet key opinion leaders in a so beautiful place, and having you around. It's excellent. We are really enjoying these days.
So, I'm curious, even from both of you, we've had quite a few presentations already. One of the discussions was all about vessel preparation, and I wanted to see how you both maybe compare in your opinions about the discussions on vessel preparation, because I know it's been controversial. You had Johns Hopkins that came out with a study that said that people were using these atherectomy devices, these plaque removal devices, too much, especially in the U.S., but vessel preparation is needed. So talk about what your thoughts are, Dr. John.
Well, the beauty about coming to Europe is that, number one, some of the technologies that we have in the U.S. are not necessarily available, and vice versa.
Good point.
And I also think that there is a little bit more emphasis on being financially responsible here in Europe than maybe in certain places in the U.S. And so, number one, vessel prep is very important. If you don't do it correctly, you're not going to have a successful outcome. And, my theory is there's no one size fits all. Thankfully, in the U.S., we have atherectomy if needed. We have specialized balloons if needed. And we have also the ability to use ultrasound to look inside the vessel, kind of see what we're dealing with to help us prepare. But at the end of the day, I think everybody would agree that vessel prep is key to a successful, durable procedure. And so everybody's a little bit different, but ultimately you just have to prep that vessel as you feel appropriate, because I think that's going to give you the best opportunity for a successful outcome.
Yeah, what do you think, Dr. Isa?
Well, we are the low budget guys, so we have a lot of restrictions, and we basically do what we have available. Most times has to do with just balloon dilation, prolonged atherectomy is getting space nowadays in, let's say, Spain, much well established in Europe, for instance, Germany or France. Mm-hmm. We are as well having IVL things already coming to Spain. I would say definitely the main issues like vessel prep is essential for a good outcome. So if we were able to have everything, I would say we were more happy. On the other hand, this is also important. Yeah, vessel prep is essential, but we have really scanty evidence related to all of this vessel prep, all of these fancy, nice tools, IVL, atherectomy, still need to prove effectiveness in terms of good quality of trials. But so far is what we have, and I wish I had all of these fancy things.
It's still fun to have all the toys, right?
It is, but it's important to, I think about using them in a judicious manner, because they are really expensive. A balloon can cost you a couple $100. The lithotripsy balloon is several thousand. So again, you can't use it, in my opinion, on every case, but you have to pick and choose. But ultimately, you have to do what's right for the patient.
But that's what you're learning here, the best practices. What are your peers doing around the world?
Yeah, and I think even though you don't have super fancy thing, you still have bailouts. You can balloon, you can pay from crack, you can pierce. Cheaper ways to deal with this sort of issues.
Yeah, just to dovetail on that, we know based on some of the recent trials for particularly a stent below the knee that balloon angioplasty works.
Yeah.
So what they do here in Italy is balloon angioplasty, and maybe bailout stenting, and that works below the knee. So that's the technique that I adopt as well.
You just have to make sure. I was talking to Marco Manzi a little bit earlier, and he was saying just make sure that when you are using the high pressure balloon and you're pumping that thing up to 30 atmospheres of pressure, that you properly anesthetize the patient. You're laughing. It's true, isn't it?
Good point. I think we always talk about the resistance of the patients comparing Italians and Spanish, and whenever I see a live case from them, and there's like the patient yelling like, wow, like a fool, I'd say, and still thinking that they done quite a long procedures compared with the Spanish guys. I would say like in Spain they are not so brave.
Well, don't you need to take a siesta then?
Yeah, I think, thanks God, even vascular surgeons, we have been introducing the nerve block and the sort of coadjuvant technology, so that make us life a lot easier, because not all of these patients are good candidates for a general anesthesia. Also. And if you prolong the procedure for more than a couple of hours, it's quite difficult just to even you have siesta.
You do. That's so true. I mean, you do have to take that into consideration. So many different types of patients, so many different comorbidities. It does take longer if you are going to prepare the vessel, if you're going to remove some plaque, if you're going to try to make cracks in the plaque to prepare for a drug-eluting balloon or a drug-coated balloon or a drug-eluting stent, so that drug can get into those cracks and get closer to the vessel wall, because it's certainly not going to do any good if it's just sitting on the plaque. It needs cells.
So let me ask you this. In Spain, what percentage of patients that you treat are claudicants versus CLI? And do you think that differs from the congresses that you go to, whether in U.S. or in Europe otherwise?
I would say that basically we don't treat claudicants in Spain, which is massively different compared with the United States. So we hardly ever treat claudicants, probably definitely on the iliacs, FEMPOP is really controversial, at least in Spain, and if you wanted to perform revascularization with a claudicant in my department, it's probably a huge discussion on the NDT. And definitely nothing below the knee.
And meaning FEMPOP bypass, femoral popliteal bypass going from the thigh to the calf.
Recanalization and endo.
Is that an insurance issue, or is it just kind of cultural issue?
I think it's cultural. I think it also has to do with evidence. And at least in Spain, the majority of patients has public insurance, so they don't pay for like in the States. Okay. And it makes a huge difference. I think that probably some over-indication has to do with the payment system.
In the U.S., they're not supposed to treat claudicants. I mean, you have to determine, there's a general claudicant, then there's someone that will complain of lifestyle-limiting claudication, meaning that no, they don't have breast pain, but if they're going to walk from the house to the mailbox, they have to stop 3 times. And I've had several patients like that before they even get to the mailbox.
Yeah, I've realized that watching your problems or listening to my colleagues from the States, the awareness of with relation regards to the patients and the sense of what is quality of life, the high standards are a lot higher in the States. They don't accept just to have like 100 meters claudication. And it's definitely make your life a lot tougher, because if you have a patient demanding, and I would say this is not something that you should ban. I accept limiting claudication as an indication for the FEMPOP segment. And yeah, we all have all of these sort of patients, young guys that feel like, I'm not a 85 years old guy. I need 55, 60 years old life. The kids running, fiddling around, and just to feel like I cannot follow them. So this is quite empowering.
Yeah, thank you so much, Dr. Isa. He's exactly right. That's why a lot of the discussions here at this conference are all about how do you select these patients for these different procedures, and we'll continue that discussion coming up right here on the Heart of Innovation. So stay with us live at CLI-C Global in Italy.
Medical Notepad, brought to you by Cardiovascular Systems Incorporated's Patient Advocacy Campaign, Take a Stand Against Amputation, and The Way to My Heart.
This is George Adams, interventional cardiologist with this week's Medical Notepad. Today we're going to be discussing the new drug-eluting balloons that are hitting the market in the United States. They're actually under trial investigation. These are balloons that allow us to treat the periphery as well as coronary vasculature in terms of leaving no scaffold behind, no stent behind. These stents are metallic scaffolds that prop the vessel open, but over time can lead to an enraged or increased inflammatory response that causes it to reblock over time. By using these new drug-eluting balloons that have limus attached to it, we are able to treat the vessel without having to leave a metallic scaffold. What's interesting about this new technology is that these balloons actually have a cell adhesion, or What's interesting about these drug-eluting balloons is that they have these micro reservoirs that have this anti-neoproliferative, this anti-inflammatory agent, the sirolimus, that is attached to this, what we call excipient, that allows it to attach to the vessel wall and elute over time, very similar to one of these drug-eluting stents that's been used in the past. And what's so exciting about this is that the preliminary data is very encouraging, that we have similar outcomes to the current strategies below the knee with plain old balloon angioplasty. Similar data, preliminary data above the knee that can compete with the current strategies to treat blockages from the hip to the knee joint. And then almost more importantly, in the heart, these blockages that form over time in the heart, rather than using a stent for some of these lesions, we can use a drug-eluting balloon to get similar outcomes. For this week's Medical Notepad, this is Dr. George Adams.
Remember, the advice and views offered during this series are for informational and educational purposes only. Always ask your own healthcare provider for explicit consent before acting on any information provided here. If you want more information on peripheral artery disease, go to standagainsamputation.com. And for real-time support, go to thewaytomyheart.org.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back to the show. We are live in Venice, Italy. This is so exciting. I absolutely love it here. I am learning so much at the CLI-C Global conference, focusing on advanced treatments for peripheral artery disease. Again, that's a circulation issue, mainly in the legs, which, if left untreated, could lead to amputation, even stroke and heart attack. So all of these doctors are gathered here in Venice, Italy for this conference. And Dr. John is taking this segment off because he is on stage at CLI-C Global, and he is helping to educate doctors on new tools and techniques for PAD. But meantime, I am holding down the fort here on the Heart of Innovation with Dr. Giuseppe Papia from Toronto, Canada. And we've been talking about a new project that he has. It's called Project Leg Saver. Dr. Papia, welcome, and thank you so much for joining us. Tell us all about Project Leg Saver.
First of all, thank you very much for the opportunity to meet and chat. And this is a great conference, and meeting people that are doing this work from all over the world is really invigorating. So I think we have the same issues as everyone in terms of creating a system where the treatment comes to the patient, because the patients are complex. They need multiple specialists, and they're not located in one spot. You add that on to the layer that patients themselves have very few means to get around to different appointments. They have lives. They can't afford devices that aren't covered, that are supposed to help them. Sometimes they can't even afford their medications or proper nutrition so that they can maintain their diabetic control in a range that is actually helpful to them. So we tackled this or are currently tackling this in Toronto and Ontario by creating a campaign that raises awareness, but also allows us to fundraise so that we can create a program that really brings together all of these elements into one spot for patients, so that it is a one-stop. And we called it Project Saving Legs. And so Project Saving Legs, and we do this at Sunnybrook Hospital in Toronto, Canada, and it's really about raising awareness. And most of the time, I get to a group And we fundraise, by the way. So unlike cancer, or trauma or heart, where people are directly touched, our patients live in a different socioeconomic place in society. So the idea around Project Saving Legs is to appeal to people that are using their legs. We have a lot of cyclists, athletes, but philanthropists to help others save their legs, right? So we have cycling events every year in the Niagara wine area in Toronto. And they're really about raising awareness, right? We don't want the cycling event to become bigger than the cause. And so every event, I'll say to everybody, who knows somebody with diabetes? And almost everybody will put up their hand. And then I'll ask, so how many people of those that you know with diabetes have ever had an ulcer or told they have a diabetic foot? And so people will raise their hand, oh yeah, my aunt had an ulcer. And I said, so how many people are aware that the day that a patient with diabetes develops an ulcer is a worse outcome than colon cancer, breast cancer, and prostate cancer combined? And most people, even some physicians, don't even know that. Statistically, they have less than half, so 54%, or fewer than 54% will be alive in 2 years because of how medically ill they are. And if they do, 70% range of amputations. And they don't know. And so sometimes they'll have this diabetic foot issue that is treated with some antibiotics, some creams for a year before somebody says, hey, maybe there's a blood flow problem. And then they get to us. And then we have to start all over. And so we are very good at addressing the blood flow issue, right? With techniques like we're learning and disseminating at CLI-C, angioplasty, just basic wound care, but they need medical care. They need assistance. They need an ability to get to their appointments. And so we said, we have systems that really manage the logistical barriers of treatment, like cancer centers. So in Ontario, in our hospital, in our cancer center, if you are a young woman that unfortunately one morning feels a lump, with a fax to a general line, within 48 hours, you'll get an appointment phone call. And then within 4 weeks, you will have had all your imaging, multidisciplinary appointments, and treatment. If you get hit by a car, we have a major trauma center. You show up, you can scoop and run straight to the trauma program, and every specialist assesses you at the same time with a CT scan, because that saves lives. If you have chest pain in Toronto and they call what's called a code STEMI, you actually bypass the hospital. So if an ambulance attendant detects a heart attack on a patient, you go directly to the cath lab, which is rating and ready, because that saves lives. And so if you're a patient with diabetes, with a foot ulcer, you can linger in the system for 12 months. And that's everywhere. Can you imagine a 2-year waiting list in a patient that has a 50% chance of being alive in 2 years? And so what we've done with our fundraising and raising this awareness and telling people just that story, because that Perning platform exists, people don't know it's on fire. And there is a tsunami of diabetes coming. Now, obviously, peripheral artery-disease is more than that. But if we're going to start with the true low-hanging fruit, that, to me, is the group. And what we've done is raise awareness. We've been able to raise funds. We've been able to create a chair in limb preservation, which I hold at the University of Toronto. It's a formal university chair that acknowledges that this is an issue that has to be, addressed. It gives me a protected time and resources to do studies, to create programs like Project Saving Legs. And what we've created is a demonstration project, which we hope for our province and our politicians, called the Vascular Limb Preservation Program. So locally, it's the VLPP. But the Vascular Limb Preservation Program is a program that now we have a dedicated nurse practitioner whose full-time job is to take referrals to the program, to the program from anyone, our emergency, our local physicians, anybody that thinks somebody with this problem can make one referral to a general fax number. They get feedback about the receipt of that. They get feedback about within 24 to 48 hours, and which is amazing because most referrals can get lost in the abyss of the fact, iCloud or cloud. But this is real feedback. We don't even want the referring physician or practitioner, because they could be community nurse practitioners, to make the decision, are they appropriate for the program? They see somebody at risk, you refer them. Our nurse practitioner has an algorithm. We'll do studies, we'll assess the patient, we'll assess the wound, and they have wound care expertise. They have an ability to refer, order tests, and they coordinate the care for that patient. And we see them in a multidisciplinary clinic with vascular surgery, with one of our rehab physicians that is an amputation specialist, and a pedorthist that can help with offloading. And the funds that we've raised will help pay for the devices because those aren't covered. And can you imagine somebody that can't afford diabetic meds being asked to pay $2,000 for an offloading device or special orthotics? And so we are trying to show that this system of care, like has been showed in every other disease-based system, like the cancer center, the trauma center, the heart program. So this is the vascular limb preservation program and center. Will save lives and will save quality of life. Now, the other thing that we're doing is we're a University of Toronto academic program. So we're creating a database to show our outcomes. We've also included a vascular quality of life measurement tool, because at the end of the day, you're saving the leg. That leg belongs to a patient. Are you actually making their lives better? What is the most important thing to the patient? Is walking, is getting back to their daily activities. And if eating properly and taking medications and offloading their foot is a very that, we can't compete with that. We have to work within that lifestyle for the patient.
Thank you so much, Dr. Giuseppe Papilla from Toronto, Ontario, Canada. Coming up right here on the Heart of Innovation, we'll have more live from Venice, Italy at the CLI-C Global Conference, so stay with us.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody, to the Heart of Innovation. We are wrapping up the show. And during the break, we're just laughing because it's so busy here. They're doing other interviews. We had to move to the hallway between the conference and the bathroom. So you might hear some footsteps, but nope, don't worry. So we're almost wrapping things up here. We've got like 4 minutes left. 2 takeaways. I'll give you mine and then you can do yours. Number one, I always leave here learning something about the procedures and not giving up. And when I leave here and then I come back to the hospital, I can channel my inner CLI-C self and say, okay, I can try this once a little bit longer. I can maybe be a little bit more aggressive, obviously in the patient's best interest. And number 2, Venice is a fantastic city. And I really, really enjoy the seafood that they have here. So those are my 2 takeaways.
I love the food, love the food, love the food. One takeaway is I'm bringing the food back. Mediterranean diet, number 1. That's a good one. And learning some new cooking techniques for those veggies. Oh, so absolutely delicious. But the other thing that I think that I'm walking away with, and I think I might do 3. The second one is I was learning from Dr. George Adams from North Carolina earlier today about new drug-eluting stents that are being used in Italy, in which the drugs act more like, did I say drug-eluting stents? Drug-eluting balloons that act more like drug-eluting stents, meaning that the medication will be distributed and penetrate over one time opportunity to try and get that vessel to calm and to slow that healing response of the vessel, which leads to it restenosis, or the reblocking or the scar tissue building back up in the artery and reblocking that blood flow. And as doctors are trying to use fewer and fewer stents or that metal scaffolding to maintain the vessel open, these new drug-eluting balloons that are being tested in Europe, and they're hoping to bring those out to results. I think that that's something to look into these events, especially globally, because we can see what's to come in the U.S. And it's why many doctors from overseas come to the U.S. to find out what's new and next there that may end up over in Europe. So number 3, I think that what I bring from these conferences back to the way to my heart and my regular workday is the relationships that I've built. And it's so amazing to see how many more doctors are continuing to learn, continuing to grow, and becoming the most advanced vascular specialists that we call CLI fighters.
Number one, it's always, for, I guess, another comment, it's frustrating when we come here to Europe because, for example, in the coronary arteries, they've had drug-coated balloons for many years, and we're still trying to get them, and those work well. So you come here and you get a little jealous because they have toys that we don't have. We've got to wrap up the show because we've got to go shopping. So Kym, take us home.
Thanks, everyone, for joining us live in Venice, Italy at the CLI-C Global Conference. And a big thank you to the conference organizers, and a shout out to the lead lady, Georgia, for making it all happen for us and providing us this opportunity. Everyone, I hope you have a fantastic weekend and safe travels for everyone headed home.
You've been listening to The Heart of Innovation with Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips. Our mission is to help patients live a better quality of life through comprehensive education, real-time support, and high-touch advocacy in partnership with thewaytomyheart.org and Take a Stand Against Amputation. Our purpose is to reduce the 1.5 million heart attacks and strokes and nearly 200,000 amputations annually. For more information regarding topics you've heard discussed on today's program, go to theheartofinnovation.org. That's theheartofinnovation.org. The Heart of Innovation is for educational and informational purposes only, and advice and views shared are not a substitute for medical advice from your own supervising physician. Do not act on any information provided in this show without the explicit consent from your own healthcare team. If you think you are having a medical emergency, call your local emergency number or go to the nearest hospital or emergency room.